Okay, but he ate a muffin. Was doing great. What is happening? I can't fix this.
What's going on?
I don't know.
Daisy, have you guys gone to surgery yet?
Hello, can you hear me?
Yes.
Hi, Adrienne. We went to surgery. The kidney looked terrible. I mean, there was some pus at the hilus, and the leak was up in the hilus area, like right up.
The leak was in the
Wasn't
mid-ureter where the ligation was.
Oh, mid-ureter with ligations. Okay, I didn't see that.
The leak was at the mid-ureter where the ligation had been. There was some momentum around it. But the surgeons were concerned that the blood supply to the ureter wasn't very good, that it looked like it was unhealthy and maybe necrotic.
Yeah. Right.
Poor thing.
So anyway, so they were, and the owners did not want to do a second surgery. So they said, if there's any chance that we would have to go back in, we would rather nephrectomy. So
yeah, so sad. But it's probably for the best.
Yeah, she'll probably be just fine.
Rachel had
kidney.
Rachel just had the kidney sitting next to her computer on a paper column, and she's like, maybe we should submit it for biopsy. And
I submitted for learning for history.
Like, I don't know, Rachel, that beef jerky ureter. Do you want to get it
actually is really necrotic, or whether it just look, like for future learning purposes.
I don't know.
How confident are we that that's actually necrotic and looks
right? Versus, but how confident are we
from sitting in your one?
Yeah, maybe. Yeah, I don't know if the biopsy will definitely tell us. Why not?
In 3 to 5 business days.
Yeah. The hospital where the incident happened is also owned by NBA, so they're paying for it. NBA is paying NBA for all of it.
Interesting. Okay, well, I'm probably going to get started here in just a second. I'll wait till, it's 2 o'clock. I'll go ahead and get started. So this is a newer paper published in the JVIM. It's a characterization of the circulating markers of the renin-angiotensin-aldosterone system in telmisartan or enalapril-treated dogs with proteinuric CKD. It's out of UGA. And was published earlier this year. So let's just make sure I can get this to work. All right. Jumping into a little bit of RAS review, the classical RAS system, basically renin is released in response to a stimuli, be that hypovolemia, hypotension, hyponatremia, or sympathetic stimulation. Renin then metabolizes angiotensinogen, which is made in the liver, to Ang1. And Ang1 is converted to Ang2 by ACE. Ang2 acts on the AT1 and AT2 receptors, where the AT1 receptor increases sodium vasoconstriction and stimulation of thirst, as well as aldosterone release, and the AT2 is counter-regulatory and anti-inflammatory, anti-fibrotic, and vasodilatory. Aldosterone acts on the mineralocorticoid receptor to increase sodium and water absorption, as well as potassium excretion, and upregulates ACE Ang2 signal transduction. So here's an image of that. You can see renin is released from the kidney due to stimuli, goes to act upon the angiotensin in the liver, is cleaved to Ang1. Ang1 is cleaved by ACE to Ang2. And then Ang2 goes on to act on the adrenal gland to release aldosterone, which then works on the mineralocorticoid receptor, as well as the AT1 receptor and the AT2 receptor. Ang2 and aldosterone excess have effects on myocardial, vascular, and renal tissues, especially the glomeruli, and lead to dysfunction. This is through reactive oxygen species generation, fibroblast stimulation, inflammation, and upregulation of inflammatory cytokines. There's vasoconstrictive effect of Ang2 due to increased endothelium expression, inhibition of nitric oxide synthase, COX-2 activation, among other things. And then the mineralocorticoid receptor polarizes macrophages from the M2 phase to the M1 phase, being M2 is anti-inflammatory and M1 is inflammatory. On the kidney specifically, Ang2 causes vasoconstriction of the intralobular artery as well as the afferent and efferent arterioles, enhances afferent arterial response to tubuloglomerular feedback, and causes progression of CKD, proteinuria development, and systemic arterial hypertension. RAS enhances sodium reabsorption, and Ang2 effect on Ang2 has an effect on the proximal tubule and the loop of Henle, whereas aldosterone has an effect on the distal convoluted tubule and the collecting duct. There are some alternative RAS pathways as well. So the alternative pathway for angiotensin generation, we have Ang112 and 125 in cardiovascular and renal tissues. And these are precursors for angiotensin peptides such as Ang2. Angiotensin 112 can be formed into Ang2 by chymase, which is an ACE-independent formation of Ang2 mediated by mast cells. There's also some counter-regulatory pathways, ACE2, angiotensin 1,7 mast access, which may be protective and induce vasodilation and increase nitric oxide synthesis. Ang1,7 is generated in the heart and brain from ACE2 processing of Ang2, and Ang1,7 in circulation in kidney arises from processing Ang1 by endopeptidases such as neprilysin. Here's just another image of some of these Ang cascades. So angiotensinogen is processed by renin to Ang1, ACE processes it to Ang2, and then we do see some formation of these other peptides. So we have Ang112 and 125 from angiotensinogen. Ang2 can be processed into Ang1,7 and Ang1,5, as well as Ang3 and Ang4. We also have the action of Ang2 on the AT1 receptor, which then induces aldosterone. As far as RAS inhibitors, the two discussed in this study largely are enalapril and telmisartan. Enalapril is an ACE inhibitor that is generally a prodrug and converted in the liver. It inhibits ACE and decreases the formation of Ang2. It also decreases degradation of bradykinin, which is vasodilatory. And there are some concerns for aldosterone breakthrough with the use of enalapril. Telmisartan is also a prodrug metabolized by the liver, but blocks the angiotensin II receptor to prevent Ang2 from binding the AT1 receptor. Blocking the AT1 receptor, regardless of pathway of Ang2 formation, may be advantageous because, as we just discussed, we have other formation methods for Ang2. And it also increases circulating Ang2, which may stimulate the AT2 receptor in a counter-regulatory manner. Again, we can see this is our RAS system, and we have the action of enalapril here at ACE, preventing the formation of Ang2 from Ang1, whereas telmisartan more so blocks your Ang2 receptor, or sorry, AT1 receptor. As far as support for use of these medications in proteinuric CKD, RAS inhibitors are considered the standard of care in proteinuric CKD, and reduced proteinuria are also antihypertensive and reduce Ang2-induced mesangial cell proliferation, renal vasodilatory effects, and slow progression of kidney disease. There's a study in a 5/6 nephrectomy model of CKD where dogs treated with enalapril had a lower UPC and lower renal tubular and glomerular lesion scores. And a double mass clinical trial showed ARBs may be superior to ACE inhibitors with a greater change in UPC with an ARB than an ACE inhibitor at day 30, 60, and 90, as well as the thought is that they have superior alternative RAS pathways. There's also a study in cats showing that ARBs are non-inferior to benazepril in cats with proteinuric CKD. Moving along to this study, they had kind of a threefold goal and hypothesis. The first goal was to compare the markers of circulating RAS, including Ang1, Ang2, Ang3, Ang4, and Ang1 through 5, and Ang1 through 7, as well as aldosterone and urine aldosterone clearance ratio. They hypothesized that there would be a higher circulators of RAS in proteinuric CKD dogs. Their second goal was to evaluate the changes relative to baseline in these markers after 30 days of treatment with either enalapril or telmisartan. And the hypothesis was that a subset of dogs with proteinuric CKD treated with an ARB or an ACE inhibitor would have increases in serum aldosterone and UACR after treatment. And then the final goal was to compare RAS between proteinuric CKD treated with enalapril or telmisartan, with the hypothesis being that circulating concentrations of Ang2 would be lower in the enalapril pets than the telmisartan pets. So this was a retrospective study. It was a limb of a prospective randomized single-center double-masked clinical trial that was evaluating antiproteinuric effects of enalapril and telmisartan, and they used controls from an unrelated RAS study. They must have, to be included, must have had serum samples at day 0 and day 30, but pets were not excluded if they did not have urine samples. As far as their population, they had 39 proteinuric dogs, and they were randomized based on azotemia and hypertension to get either enalapril or telmisartan. They must have demonstrated persistent proteinuria with a UPC of greater than 0.5 if azotemic and greater than 1 if non-azotemic. They were excluded if they had external causes of proteinuria, were undergoing a treatment that might affect proteinuria, were hypotensive or hyperkalemic, or if they had received a steroid or a RAS inhibitor within 14 days of enrollment. They did not exclude dogs who were on amlodipine and they did have a decision tree for treatments to get to somewhere between 100 and 180 millimeters of mercury for their systolic blood pressure. They also had healthy controls. These were dogs from a different study, and they were life stage and sex matched healthy dogs that had evaluation to make sure they were healthy. The UPC was only performed if the dipstick protein was 1+ or greater, and the USG was greater than 1040. And they didn't do a UPC on all of the dogs who had a dipstick protein of greater than 2+. These dogs were excluded if their UPC was greater than 0.5. They were also excluded from the healthy controls if they had cardiac, endocrine, respiratory, renal, or urinary disease. So as far as their analysis of RAS, they measured Ang1, Ang2, Ang3, Ang4, Ang1 through 5, and 1 through 7, as well as aldosterone. And then they also calculated surrogates for renin, ACE, and ACE2, as well as adrenal responsiveness to Ang2 signaling aldosterone. And these were labeled as the PRAS, ACE-S, ACE2S, and AA2 ratio. They additionally measured the UACR in these pets. As far as statistics, they did descriptive statistics for the demographic and general clinical pathologic data and examined these for normality and presented as a mean plus or minus standard deviation. For mean serum equilibrium concentrations of Ang1, 2, 3, 4, 1 through 5, 1 through 7, aldosterone, as well as mean UACR, AA2, PRAS, ACE-S, and ACE2S, these were calculated for control and pretreatment groups at baseline. And they calculated for the proteinuric CKD groups at day 0 as well as day 30. And these were represented as a mean concentration calculated for each dog. They adjusted models for amlodipine, age, heart disease, and as there were no effects found in any of these adjustments, they therefore reported the unadjusted values. And they assessed differences between treatment groups using linear mixed models. It was a mixed Tobit censored regression model for variables with values below the detection level, and restricted maximum likelihood estimation degrees of freedom using Kenwold-Roger procedure. Normality of residuals was assessed using normal quartile plots and Shapiro-Wilk test. All tests assumed a two-sided alternative hypothesis, and p-values of less than 0.05 were considered significant. Moving on to their results. So of their animals, 36 of 39 dogs had samples on day 0 and day 30. And then of those 36 dogs, 33 of them had urine samples available. They had 20 of those dogs that had 20 of the proteinuric CKD dogs that had life stage pair matched healthy controls, and 18 of the 20 controls also had urine samples available. As far as clinical data, the mean blood pressure was prehypertensive in the proteinuric CKD dogs and normotensive in the controls. The mean BUN and creatinine were non-azotemic in both groups. Only 4 of the proteinuric CKD dogs had a creatinine of greater than or equal to 1.4 milligrams per deciliter, and only 1 healthy dog even had a UPC performed. No control matched proteinuric CKD dog was receiving amlodipine, but there were some in the group of proteinuric CKD dogs that were. As far as diet, 30 of the 36 proteinuric CKD dogs were receiving a commercial prescription renal diet, and all but 1 of the control dogs was fed a non-renal commercial diet. As far as baseline RAS analytics, circulating RAS in dogs with the proteinuric versus controls showed no significant differences between the mean serum equilibrium concentrations of Ang2, Ang4, AA ratio, AA2 ratio, PRAS, and aldosterone in the proteinuric CKD control groups. The proteinuric CKD group had a significantly higher mean serum equilibrium concentration of Ang1, Ang3, Ang1 through 5, Ang1 through 7, and UACR. The proteinuric CKD group also had a significantly lower ACE-S and higher ACE-2S, which were those 2 calculated values. This is a document from, it's one of the figures from the paper showing at baseline the healthy versus the proteinuric CKD pets and their metabolites. And there's, I added a red star for the statistically significant ones. So Ang1, Ang3, Ang1 through 7, and Ang1 through 5 were statistically significantly different. Moving on to their results, moving on to the results of the circulating RAS in dogs with proteinuric CKD before and after treatment with enalapril and telmisartan. 17 of 13 pretreatment dogs received enalapril and 19 of 36 received telmisartan. Urine was available for UACR in 16 of 17 enalapril and 17 of 19 telmisartan dogs. 5 of 17 enalapril and 4 of 19 telmisartan dogs received amlodipine, so it was fairly evenly split. There were significant differences on day 0 between the enalapril and telmisartan dogs in Ang3 and Ang4, both of which were higher in the telmisartan group. There was no difference between serum Ang1, aldosterone, PRAS, and UACR in both groups between day 1 and day 30. PRAS, as a reminder, is a surrogate for renin, was significantly increased from baseline in each group at day 30. Telmisartan group had significantly higher Ang1, Ang2, Ang3, Ang4, as well as Ang1 through 5 and 1 through 7 than the enalapril group on day 30. And there were no differences between the groups for ACE-S, ACE-2S at day 0, but at day 30, the enalapril group had significantly lower ACE-S and ACE-2S, while the telmisartan group had no change from baseline. AA2 was only able to be calculated in 11 of the enalapril and 14 of the telmisartan dogs, and there was a significant decrease from the AA2 and telmisartan dogs from day 0 to day 30, but no change in the enalapril dogs, as well as a significant decrease on day 30 between the telmisartan and the enalapril group. Aldosterone was decreased in both groups on day 30, but there was no effective UACR in either group. And so here you can see another figure, the difference between the enalapril group on day 0 and day 30. So you can see that significant increase in Ang1, as well as changes to Ang2 and Ang1 through 5. This is the telmisartan treated group baseline versus day 30, and this one's pretty significantly more impressive. You can see a pretty significant increase in all of the groups, most of the groups, so Ang1, Ang2, Ang1 through 7, Ang1 through 5. And interestingly, this difference here was not calculated to be significant. They didn't include those numbers aside from this image, so it's a little hard to visually compare, but was not considered statistically significantly different. Let's see. As far as a summary of their findings, so a greater serum equilibrium concentration for ANG1, ANG3, ANG1 through 5, and 1 through 7, and a higher ACE2S and UACR, as well as a lower ACE-S in dogs, was found with proteinuric CKD compared to those healthy controls. ANG2 was significantly lower in dogs with proteinuric CKD treated with enalapril than those treated with telmisartan, which is consistent with their hypothesis. And the telmisartan group had a significant increase in ANG1, ANG2, ANG3, ANG4, as well as ANG1 through 5 and 1 through 7 than the enalapril group on day 30. Aldosterone breakthrough, characterized by increased serum aldosterone or UACR from baseline, was present in 11% and 40% of the RAS-inhibited drugs, respectively, which was similar in proportions to the treatment group. As far as topics to be discussed, so there is an upper regulation of the beneficial RAS peptides suggested by the increase in the ANG1 through 7. This occurred in both enalapril and telmisartan groups, but was significantly higher in the telmisartan group. This is likely due to increased ANG2, and increased ANG2, ANG3, and ANG1 through 7 in telmisartan is theoretically advantageous. Attenuation of inflammation. This can lead to attenuation of inflammation, oxidative stress, fibrosis, and systemic hypertension. Enalapril resulted in significant decreases in ACE-S and ANG2, as predicted, and telmisartan resulted in significant increases in ANG2. The AT1 receptor blockade results in increased release of renin via inhibition of negative feedback on renin release, and higher ANG2 action is otherwise blocked by the AT1 receptor blockade. As far as aldosterone breakthrough, 10.5 and 11.7% in the respectively the telmisartan and the enalapril group showed to have elevated aldosterone. 47.1 and 50%, again, telmisartan and enalapril showed increase in UACR from baseline. UACR has more influences and is thought to be an inferior measurement, and so they postulated that perhaps the just measuring aldosterone would be beneficial, in which case we see less of a change. There was not any significant effect of amlodipine on RAS, which contrasts with prior studies. However, there's very small numbers. There's 9 patients in this study that were on amlodipine. As far as limitations, this study had a pretty small sample size without a power calculation, and the study is quite underpowered. There are few hypertensive dogs and few azotemic dogs, and then they had imperfect testing for proteinuria in their controls. This is additionally a retrospective study, and timing of sample collection, diet, and additional sample collection were non-standardized. There's a couple of human literature papers suggesting that RAS just drastically changes versus AM and PM, and so would potentially be interesting to monitor the timing of those effects. As far as future directions, they had additionally, they could potentially additionally evaluate for the importance between classical and alternative RAS pathways, or have a larger study including more significant chronic kidney disease, larger numbers, and a higher iris score, as well as more significant hypertension. They could additionally evaluate other medications blocking RAS, including combination of ARBs and ACE inhibitors, versus combination drugs such as Entresto, which is an ARB, and neuroendopeptidase inhibition. So I realized that I talked really, really fast. I'm very sorry. Does anybody have any other thoughts on this paper as far as critiques or thoughts on the findings? I will say that when I was reading the results of this paper, I found a couple of things that were a little bit confusing, and maybe others did as well, really just in the way that they presented. So when looking at their goals, which I'm going to go back here, they were really wanting to have kind of a threefold goal here. So comparing the markers of circulating RAS, as well as evaluating changes from baseline. But then finally, this third marker comparing enalapril versus telmisartan. And I did think that when they were presenting their results, it was a little confusing to differentiate what they were trying to get at versus 0.2 or 0.3. They were presented a lot of the times kind of as an amalgam. And I thought it would have been kind of nice to have the differences between enalapril and telmisartan really shifted out. So if you look here, we have our enalapril treated versus our telmisartan treated. So I just kind of copied and pasted this slide, comparing what these 30-day results were here with the enalapril dogs versus the telmisartan dogs. And I think that this was a missed opportunity to really discuss further the kind of significant differences here between the peptides that we see in the telmisartan dogs versus the enalapril dogs. When presenting the data, they kind of lumped it all together, and I think that that was a missed opportunity to really show some light on the differences between these two medications and how they may affect our RAS proteins. Did anybody else kind of find that when they were reading this paper?
I thought it was a great step forward in trying to get an understanding of the whole pathway, because I think for a long time it's just been simplified as just the effects of Ang2 and Aldo, and then that's it. So I think it's a great step in knowing what the drug do. To me, and I'm kind of bypassing your question a little bit, but for me, I really wonder like what the overall clinical relevance of it is, and to what extent it might have benefits or detriments to our patients. And I think even going back for a long time, we've looked at even just the effects of Aldo and Ang2 for drugs like amlodipine. And there are some institutions that are very strongly of the opinion that if you're giving a dog an ACE inhibitor because it showed, if you give them amlodipine, because amlodipine has been associated with an increase in Ang1 activity, that they need to be on an ACE inhibitor at the same time, that you can't just give amlodipine by itself in dogs. And I think that's mostly out of data that was done at NC State, which is certainly not the way that I have approached things, to feel like it was necessary that they needed to be on an ACE inhibitor or some type of RAS inhibition if you were using just amlodipine in these patients. And if you look at people, they certainly get amlodipine all the time without being on any RAS inhibition whatsoever. So I love that we're diving deeper into it and get a better understanding of what's happening. But I think we have a history of kind of looking and seeing some of these changes and instantly applying to how we're going to manage patients clinically. And that may or may not actually be justified by real world changes in outcomes. Like if the patient doesn't have a different survival, if their Aldo goes up a little bit or their Ang1 or Ang2 goes up a little bit, then maybe it's not significant. It's just a reflective of physiology, versus if these patients do have different outcomes and then we can elucidate if it's because of these various intermediaries or players in the RAS system, then it might provide all this additional opportunity for us to manage it. But we just don't know that. So this is, I think, a great step forward to get some better understanding, but we need to look at this in our patients to then say, okay, well, what about those patients who were managed and had different levels? Can we see, are they associated with survival or different outcomes, and actually see if they're clinically relevant or if these are just markers of the physiology that might not actually have clinical bearings.
Yeah, I think that's a great point. I do think getting in this study specifically, I think a lot of this was taken from a different prospective study that they were putting together that I believe is looking at the benefit of telmisartan over enalapril. And so I do think in the study the study that they did with this data that is published elsewhere, I believe showed that telmisartan did show a more persistent lowering in UPC. Obviously, again, more data is always better, but I think that that was kind of interesting to read with the lens of, you know, this was part of an additional study.
Yeah, absolutely. And while the other work showed that telmisartan was more effective in various metrics at reducing proteinuria, what we don't have yet is to have a study that shows, well, that reduction in proteinuria is associated with an improvement in survival and a better outcome that's associated with it. Because it could be as simple as just, well, if you get the maximal reduction in UPC, is that associated with improvements in survival? Or does it come down to some of the players involved might be some of these shown on the slide that might be playing a role that could affect things as well. So, you know, I think we've done a number of studies showing the risk factors for things to go poorly in kidney disease: hyperphosphatemia, proteinuria, hypertension. What we haven't shown effectively at all, and this is actually quite true for a number of states and for human medicine as well, is that if we correct any of those things, that they're actually associated with a better outcome. You know, we have no evidence to say, well, if you have a proteinuric CKD patient and you manage them and you normalize their UPC, that they have a better survival than if you didn't do anything. We just have the risk factors associated with survival, but no data to show that the improvement actually results in anything. And I think that's obviously the big picture. We want our patients to survive. We want them to live longer, have a better quality of life. And this provides us more information on potential targets for that. But we need to, we need to just look at this not only for efficacy, which has been done in terms of proteinuria reduction, but the real hard work is the long-term longitudinal studies looking at outcomes, because the ones that we have on ACE inhibitors and RAS inhibition, like the Benric study, are not, I think, adequately dosed for the ACE inhibitors that were used, and they didn't see a difference in survival. But I worry if that we just didn't actually treat them with a high enough dose of the drugs, and certainly none of this fingerprinting was done. So now we need to do these longer longitudinal studies with fingerprinting and be able to capture enough data to actually try to make sense of it. So it's exciting in that regard.
I agree. Thanks for those comments, JD. Heard Hattie SAIM say before, that the higher proteinuria in cats is a marker of progression, but can you change their category? If you lower their proteinuria, do you really affect the outcome like you're talking about by lessening the proteinuria? I think similarly, the AND7 that's purported to have beneficial effects, does that equate to improved outcomes?
Yeah, which is very cool now to have this as a tool that we can use to study that. So I'm very eager to see what comes out as the next steps, to use this as a better way of looking, rather than just something simple like blood pressure or UPC that we know has limitations to its accuracy as well, but as this will, but at least it provides us more data to try to make some sense out of the muck that we see.
Did anybody else have any thoughts on this paper?
I enjoy the figures and trying to wrap my brain around them.
Yeah, it took me quite some time. I feel like I spent a lot of time kind of staring at them. I did look into where they were getting a lot of their fingerprinting done, and it looks like there's a lab in Vienna that does a lot of these fingerprinting. So it seems like it's available for research, but more available than perhaps historically it has been. Okay, well, guess if nobody else has anything they would like to say, suppose we could end things a little early. Don't know that I have the ability to do
No,
that.
I can do that. That's just fine. So we
Okay.
have another one on Monday, so we will see you guys Monday as well.
Oh, you know what? I
Thank
didn't
you.
check the chat. I'm sorry.
Thank you, Adrienne.
Oh, thank you.
Yeah, nice work. Really appreciate it.
Thank you.
Good job, Adrienne. Thanks.
Thanks. Bye.